Thank you so much for that very warm welcome, and I just want to again extend my welcome and thanks for all of our distinguished guests. I'm really happy to speak with you, and for the keynote address. Oh, thank you. Great. I wanted to share a story of the process that we went through. So when we spent the last at eHealth Africa, we spent the last 15 years or so developing various digital data-driven interventions and innovations. And something occurred a few days ago where I was reading about some of the challenges with innovations in global health, and it really kind of struck me because one of the things that we do is we get really excited about solving a particular problem. We fixed a data system for managing some of the polio campaigns. We supported supply chain interventions for vaccines in multiple states. And all of those individual innovations were successful and accomplished their goals. But then when you kind of step back and you have a wide angle view of the healthcare, of the public healthcare and private healthcare system in Nigeria and in parts of Africa, you realize it feels like we've not moved the needle much. We've been very successful at our innovations, but then connecting those innovations into a system that can consistently deliver the kind of healthcare that people deserve, that our families deserve, there's still some missing pieces. So in 2014, 2015, we embarked on this journey. We spent a lot of time at ribbon cuttings for primary care centers or renovated hospitals or these kinds of things. But I remember standing there as we were cutting one of these ribbons thinking, there's not a single person in this ceremony that's ever going to use this primary care center. Not the governor that was there, not me, not the donors that were there. And that do we actually solve this problem? How do we build the primary care, the healthcare system that we deserve, that we want, and that we will use? And how do we make that accessible? So we started by looking at the problem. So we looked at the space and said, okay, if we're going to start from somewhere in the primary care space, where do we start from? So the first thing, and also timing-wise, in 2015 was also when the Lancet Global Commission on Healthcare Quality was formed. And so it was quite fortunate timing, because then that report and the data behind it really drove a lot of our thinking. And we came up with these things. So we kind of formed our problems. So one of the main problems we realized was this massive issue of quality. So much of the previous 10 years of working in public health, we focused on access. How do we get people access to healthcare? How do we get people access to medicines? But without thinking, what is the supportive system to make sure people are getting the right diagnosis, getting the right medicines, getting the right treatment? Just to poor quality health. So these people had access to the healthcare system, but received the incorrect care. They showed that 28% of antenatal care, 26% of family planning services, 20% of sick child care across these countries qualified as effective. But, despite all this considerable variation of healthcare design across the world, most countries had the same gaps. Preventable harm to patients was too common, both inside and outside hospitals. And widely, clinical and hospital practices were not evidence-based. There is another data point in here that said about 45% clinical guidelines for common conditions are followed less than 45% of the time, according to this commission. So then, right, that framed a problem that it looked big, but then we said, okay, well, that's fine. Like let's address quality. Let's build that. But then we realized, okay, the systems to support that quality delivery were also missing from the environment. That involves training programs. That involved, even when we looked at the data systems available, like your classic EMRs and things like this. Most EMRs are there for data input. Put the data in, you go away. The data is not used to make decisions or improvements in the quality of care. So we had to rethink the whole foundation of what an EMR is so that the EMR can give us the appropriate information and decision points to improve quality at the end of the day. And that last one there was, just like I said, customer-focused care. Modern health systems failed to provide care that is focused on the patient's family needs and expectations. And designing a system that really did put the patient at the center of the decision-making, involve them in the decision-making, involve them in the design, so that they're getting what they want and what they need out of this experience. And, because it's not just about treating individual sickness, collecting, money and sending them home. It's about thinking about their life quality, their desired outcomes, and putting that into the system as well. So then what did we do? So then we kind of framed, okay, we stepped back and realized we had to build a lot of infrastructure. So we began building what we consider this healthcare delivery platform. So we needed information systems, we needed training programs. We found out, we needed supply chain, we needed diagnostics systems, because everywhere we looked, we found systems were lacking. So then we realized that we had to then build those systems, bring them in-house, and figure out how to make them, figure out how to integrate them and use them across our things. We wanted to deliver exceptional primary care. So there's a framework that came out of the University of California called the principles of high-performing primary care. So we adopted these 10 principles into our daily functioning and working as a system. And then we set out later on, after we created these things, we set out to create a quality healthcare ecosystem. So if we're spending all this time, all this money building this infrastructure, how do we get other people to use it? So it's not just for us. We didn't build it just so we can, and everyone else can wait. So now we've partnered with about a dozen digital healthcare providers who you might use over WhatsApp or over one of their apps. On the back end of a lot of those digital health providers is our supply chain, our quality management system, our tools, our system, our clinical guidelines, because we wanted to make sure that we could not just use this ourselves, but we could actually change some of the functioning of the ecosystem around us. And so there's several areas where that's playing out now, including now in the last 3 to 6 months, including discussions with government, where we're taking our learnings, figuring out how to pair that with the public system, and how do we partner with governments. Some of our team is not here today because they're in Edo State signing an MOU with the primary care development agency there to manage several primary care centers as a service, as a partnership with the government. So really, again, it's about building this ecosystem, figuring out what works, and making sure other people have access to those tools, those systems, those guidelines, those technologies that we've seen have driven our care. I wanted just to step back a little bit, because what I realized is this was about system building, and I'll go a little bit quickly through some of these. But it is really interesting when you step back and you say, okay, we want to address a systemic issue. So one of the things, look at themes that you see across a lot of these is the ability of someone to stand up and say and point out something that's wrong and ask for it to be fixed. There was, when Atul Gawande did his work with Harvard on the checklist manifesto, they came out with a list of 10 criteria for the WHO safer surgery checklist. One of the top criteria that had a huge influence on the outcomes of surgery was whether or not the surgeon knew the names of everyone in the room. If your surgeon knows the name of everyone in the room, your outcomes for surgery increase, success rate increases by 50%. Just that simple step, which means communication became the foundation of what we had to start. So it wasn't, we could just start implementing quality and assume everyone's just going to raise their hand and speak out when they don't have the training to do that. They don't have the systems, they haven't had the experience in the healthcare system to do that. So one of the first things we started doing is working on conversations, working on communication skills, empowering frontline healthcare workers in our system to come and tell our managers when they see something is wrong and, you know, point those things out. And again, ask for them to be fixed, because this is about having those things. And some of these studies, which you can find, like Crucial Moments, this ability to speak out. So then once we built that foundation, once we started building that foundation, it's a continuous effort. We then looked at systems for how do we design quality improvement in healthcare. So we looked at things like lean healthcare. John Toussaint, who's and Kim Barnes, who are pioneers in the area of lean healthcare systems, and how hospitals and clinics can implement quality management systems as part of their work. Another Atul Gawande, the heroism in incremental care, was also quite inspiring, because it looks at how do you treat people, not how do you treat illnesses or sicknesses or conditions. It's about how do you build a relationship with someone in a healthcare system so that they can arrive at a diagnosis. And so you look at examples like cancer treatment. The average person that gets diagnosed with cancer, ends up can sometimes take up to 3 years in certain systems, because that relationship isn't there to increment and figure out what's wrong and work with people to solve their problems and to listen to them. And so those were all kind of instrumental things. I mentioned the 10 building blocks to primary care, and how this all works. So again, the 10 building blocks of high performing primary care, starts with all these things like engaged leadership, data-driven improvement, team-based care. One of the things that we've done in our clinics is figure out how to get clinicians to work on teams. And, it's a much harder problem to solve than you imagine it, than you think, because you get a room of doctors, nurses, pharmacists, lab techs, dental hygienists. They've never, ever sat in the same room together and made a decision together. It's just never happened. It's never happened in their training. It's never happened in their medical school. It's never happened when they did their residency. So bringing those people together for the first time and saying, this is now a team, and we take care of our patients as a team. It's not the doctor leads. It's not the manager leads. It's the team that manages and supports that patient, that family. And building those things. Each one of these was several months, if not years, in the making, to figure out what was going to work. How do you change culture? How do you change conversations? How do you change the way that people are willing to work, and put patients, families center to that decision, not egos, not training, not seniority. I know this is a conference about digital tools, but I will get there. But what I'm trying to explain is that, so when we look at our digital tools within EHA clinics, it's not about individual innovations. We're building those tools so that they support this process. Our EMR now lets us do chart reviews, but it lets us do not just chart reviews by the manager, so someone can, okay, well, let me give feedback. We now do team-based chart reviews. So your peers will get assigned to review your charts and give you feedback. That's a super complicated process in terms of the breaking down those barriers to having that conversation, but we had to build the technology to support that, to build that conversation into the system, not as an add-on or a side thought. We had to think about how do we use the system to break down those barriers, support those conversations, support team-based care, because these are all things that don't exist in the EMR world. The EMR world is about data collection and mostly billing, and we had to rethink the process from the ground up. We created our True North, and there is a data system in our EMR and in our other systems that supports each one of these pieces, driving us towards zero harm, improved health outcomes, reducing wait time to zero, reducing waste, people in the system, in continuous learning, and then designing our system for impact, making sure that we're looking at improved outcomes for our patients, our families, and the community at large. And it's our digital systems, our data systems that now enable to do this at scale with consistent quality, and now with affordability. Because when we started building the system, we knew it wasn't going to be cost effective, but very rarely the first product is the cost effective one. We knew we were going to innovate and use the system to drive this cost down, improve our operations so that now we can deliver the same quality of care that we all expect that we get from our clinics at the community level. Same clinical protocols, same processes, same quality management systems, but improved operations to deliver healthcare where people want it, how people need it, and how they can afford it. I'll just take you through some of the things that we've been building on the technology side. So we've got our kind of GetCare suite of tools from GetCare Plus, which is how we manage relationships with our clients. GetCare Pro is a system that we developed. I mentioned for the digital health companies that we work with, but it's the back end for our what you would call our business to business work, how we support other healthcare businesses to use our supply chains, our clinical processes, businesses, their own systems. Reach, which some of you in the room know about, but like I said, we challenged ourselves several years ago after we had EHA clinics up and running. We said, great, take this exact same quality, take it into the poorest community in Kano that you can find, and figure out how to make it work. Figure out how to make it work operationally, figure out how to work to make it financially. We're still getting on the finance part, but partnerships and groups are supporting that. HealthMate. We recently launched EHA Pharma, which we realized one of the ways to drive down the cost of healthcare in the communities that need it was to manage the supply chain from end to end. We tried working with the various third parties, various other integrators and wholesalers, but at the end of the day, we needed to manage the supply chain because the difference of even 10 naira affects whether or not someone can afford their antibiotics, their hypertensive medications. So by fine-tuning that supply chain, controlling it from end to end, and optimizing it, we've been able to do that with incredible success. Huddle is a new platform that we're launching around healthcare recruitment and training systems. We've got a lot of partnerships that we're launching in the next couple of months around healthcare training and recruitment platforms. And then EHA Care is our internal platform of suite of tools. It's a digital health platform that has several different applications depending on who's using it, whether it's in the clinic or in the community. And then our eHealth Observatory and Research is a platform that we've created to inform ourselves of what's happening in the communities that we serve. So this gives us population level insights. We look at infection rates for various, whether it's, the seasonality of malaria. It lets us see in advance from a population standpoint if certain infections like typhoid, like cholera, are popping up, and so we can actually deal with them as a system and not just individual patients and families. We can take the broader context of the system working into account when we make those decisions. And so that kind of brings us to how we use digital systems and health and our platform to drive this. So again, I want to thank you for indulging me on this journey and our discussion, and welcome to the Insights Learning Forum.